Good evening. I'm Dr. Suede. I'm talking on behalf of IMCRA, and in this video we're talking about two general surgery emergencies that we can see, and I described how to take care of the patient from a basic standpoint. The first condition is acute appendicitis, and we're going to describe the symptoms and the signs and diagnosis of acute appendicitis. The treatment is, in these conditions, the treatment is going to be antibiotics, but if the patient is not improving with antibiotics over a period of 24, 48, 72 hours, especially if the patient's showing signs of sepsis with low blood pressure, increasing abdominal pain, showing signs of perforated appendix, then surgical intervention might be indicated. In these situations, we're expected to have local anesthesia, so sterilizing the abdomen with alcohol, trying to isolate the surgical site with clean towels or sterile towels if present. Infiltrate the skin and the subcutaneous tissue and the muscles with the local anesthetic. Then with a surgical scalpel, incise the skin, the subcutaneous tissue, the fascia, separate the muscles, open the peritoneum. Upon entering the peritoneum, if there is frank pus in the peritoneum, I think the only thing at that point to do is put a drain in and close the abdomen, and this way we can save the patient at least from sepsis by draining the abdomen, draining the pus, and referring the patient after that to a surgical center where appendectomy could be done later. If there is no pus in the peritoneum, then we need to try to find the appendix by sweeping the index finger in the right lower quadrant, trying to find a sausage formed, sausage-shaped structure, lifting the appendix out of the abdominal cavity, controlling the blood supply and the base of the appendix with 3 surgical ties, cutting the blood supply, cutting the appendix, leaving two ties on the patient's side, and then closing the incision with sutures. The second condition is incarcerated inguinal hernia. Usually the patient will come in with a known history of hernia. All of a sudden the hernia will become irreducible. The patient will complain of severe pain in the groin with a painful mass that's non-reducible. They usually will have signs of bowel obstruction, so abdominal distension, nausea, vomiting, obstipation. First thing, we have to try to reduce the hernia by controlling the patient's pain with analgesics, putting the patient in a supine position, lifting his feet up, gentle massage over the groin area to try to reduce the hernia. If the hernia is non-reducible and the patient is getting worse, especially with more signs of bowel obstruction, then we suspect that the bowel is strangulated. It's a strangulated hernia. And again, a surgical procedure is indicated in this case to save the patient's life by using local anesthesia, sterile technique as much as we can, making a small incision right over the hernia, opening the skin, the subcutaneous tissue, and the layers one by one until we get to the hernia sac. Opening the hernia sac, taking a great care not to injure the bowel any further, opening the neck of the hernia, and trying to reduce the bowel intra-abdominally. If we're able to do that, I think that's the best thing, and once the bowel is reduced, closing the hernia and closing the muscles with any kind of sutures we have, and closing the skin, putting a sterile dressing, and referring the patient to a surgical center. The care after the operation, again, keeping the patient on antibiotics, nasogastric tube suctioning for bowel rest until there's bowel activity, and taking care of changing the dressing once a day and once the patient is able to eat, then put them on high protein diet to allow them to help them heal their wounds.